Hello, everyone. Welcome to ASRA's annual meeting in Las Vegas, spring of 2022. Thanks for taking our peripheral nerve block for knee surgery workshop. Hopefully you'll get some tips from the experts that are teaching at the bedside, and you'll have some good questions for us as well. So I have a short introductory presentation here. I just have to give a few disclosures. First, I do receive royalties from UpToDate for authorship, and recently released a novel, interestingly enough, about anesthesiology, for which I will receive royalties, presuming that it sells any copies. Now, on to the real business at hand. We're going to talk about 4 blocks for knee surgery, 2 of which are a little bit more antiquated, 2 of which are probably the more current situation. We'll talk about femoral and sciatic block, and then we'll talk about the blocks that we use much more commonly now, adductor canal block and the injection between popliteal artery and capsule of the knee, or IPAC block. Femoral nerve block provides sensory coverage for the anterior thigh, the anterior knee, and the anteromedial calf down to the medial malleolus, as well as into the joint of the knee, as well as the joint of the hip, and also provides possibly some medial joint coverage in the region of the medial malleolus. It provides motor function to the quadriceps and sartorius muscles, and therefore is potentially useful for knee arthroplasty, unicompartmental knee arthroplasty, ACL reconstructions, osteotomies, and more complex arthroscopic knee procedures. But what we've seen over the past decade is an evolution away from this block because of the increasing demands for patients to be able to walk immediately after or soon after surgery and improve their rehabilitation opportunities. Here we can see a gross anatomy specimen and a cross-section. In the gross anatomy, you can see the nerve is already beginning to branch at the level of the femoral crease and the typical pattern nerve artery vein. It lies on top of the iliopsoas muscle and under a fascia here called the fascia iliacus. In this cross-section, it can be seen lying right over, and the nerve is essentially embedded into the surface of the iliopsoas muscle. There's a vascular compartment right next to it. Superficial to the fascia iliacus is the fascia lata, so there's usually 2 layers of fascia that we have to go through in order to block this nerve. This cross-section illustrates the fascia iliacus and how the nerve is embedded down into the iliopsoas muscle. Again, nerve, artery, vein. It lies just lateral to the femoral artery. Fascia lata is here in the more superficial layer. An ultrasound shows us the nerve lying again just lateral to the femoral artery, and stretched across it is that fascia iliacus. Placing the needle in this diagram in either the superficial position just on top of the nerve but through the fascia iliacus, or lateral to it or just under it. Any of these positions will be fine. If you put local anesthetic there, the fascia helps to keep it around the nerve, and therefore it bathes it in the local anesthetic and provides a fine block. One can also simply put the needle down through the fascia iliacus and put local anesthetic on top of the muscle between it and the fascia, and it will spread here both medially and probably laterally to capture the lateral femoral cutaneous nerve. Next, the adductor canal block. The adductor canal block has essentially almost replaced or come close to replacing the femoral block. There are situations where a femoral block might still be useful or necessary, but more often we'll see the use of the adductor canal block, which primarily affects the contents, of course, of the adductor canal. In terms of the neurologic structures, this is reliably the saphenous nerve and the nerve to the vastus medialis. So sensory input to the medial aspect of the joint, and of course the infrapatellar branch of the saphenous nerve, as well as all the coverage down the medial calf and ankle. The nerve to the vastus medialis, of course, provides motor input into the vastus medialis muscle, but also sensory branches into the joint along its medial aspect. And since many incisions, particularly for total knee arthroplasty, are made in a medial parapatellar position, this provides adequate analgesia. A number of randomized trials and several meta-analyses have shown less motor effect with relative quadriceps sparing and equivalent or at least non-inferior analgesia in total knee arthroplasty when this block has been used and compared to femoral block. So we've seen a major shift to this block for total knee arthroplasty and in a number of other knee surgeries, including ACL reconstruction. This cross-section simply illustrates the position of the adductor canal deep to the sartorius muscle and sort of on the anteromedial aspect of the thigh. Here's a cross-section together with an ultrasound image showing that just deep to the sartorius muscle is the artery, the femoral artery, and deep to it is the vein. And frequently then we would expect to see the the saphenous nerve lying in a lateral position along the edge of the artery. The nerve to the vastus medialis is often in the interface between the sartorius muscle and the vastus medialis, which is the next muscle laterally. The needle can be placed either through the sartorius muscle to access this adductor canal, or it can be brought between the vastus medialis and the sartorius muscle. This ultrasound also shows the saphenous nerve in this region. Typically, there's a hyperechoic sort of a triangle here, and the saphenous nerve is within this connective tissue. It's not always discrete. In fact, it's often not discrete, but placing local anesthetic in this region and distending with local anesthetic should provide an adequate and appropriate saphenous nerve block, as well as blocking the nerve to the vastus medialis. As I mentioned, sciatic nerve block is also somewhat antiquated compared to other techniques, and the reason why is because we again have this emphasis on preserving motor function, and the sciatic nerve block is going to take away all the motor function below the knee, just as the femoral nerve will take away quadriceps function, either of which is going to make it difficult for anyone to participate in immediate or early physical therapy. Sciatic nerve affects all sensory function below the knee except the saphenous that we mentioned earlier, but also provides joint innervation for all three of the major joints of the lower extremity, the hip, the knee, and the ankle. It supplies motor innervation to the hamstrings, and again, everything below the knee, the peroneals, the gastrocnemius, soleus complex, the tibialis anterior muscle, and the foot intrinsics, the short flexors on the bottom of the foot. Sciatic can be blocked at many levels. With ultrasound, it can readily be blocked at the gluteal level, the infra or subgluteal level, just under the buttock, the mid-thigh, and even in the high popliteal sites. A high popliteal block can also be useful for reducing posterior pain in the knee. It is commonly utilized, it used to be commonly utilized with femoral block for arthroplasty and more selectively for other knee surgeries until we saw the pivot towards earlier ambulation. And again, this is a block that you might call upon in certain situations, but will be much less likely to be used, as we'll discuss at the bedside for our workshop. Here's an ultrasound of the sciatic nerve in the mid-thigh. Typically, the biceps is lying superficial to it. The adductor magnus is lying deep to it. If you're in the mid-thigh, you may see the vastus lateralis lying lateral to it. It's often a wedge-shaped nerve, fairly deep, 3 to 4 centimeters. This is a thin specimen, thin person, but it's often 3 to 4 centimeters deep, and it can be relatively isoechoic with the muscle and be difficult to see. It's more easy to see, of course, in the popliteal fossa and at the very lower part of the buttock, where it's lying between the two bony landmarks of the greater tuberosity and the ischial tuberosity and the greater trochanter of the femur. Lastly, let's mention the IPAC block, the injection between the popliteal artery and the capsule of the knee, so-called IPAC block. This is a fairly recently described, of the three probably most recently described. It's a plain block that is to provide analgesia to the posterior part of the knee. There is a plexus that develops and is sort of wrapped around the femoral artery, the popliteal artery, that is, behind the knee, and small fibers come from that to the posterior aspect of the knee. This plexus is made up primarily of nerves that come from the two aspects of the sciatic nerve, the common peroneal and the tibial nerve. There may also be input from the posterior deep branch of the obturator nerve. But again, it targets small fibers which course from this popliteal plexus to the posterior capsule of the knee. So in essence, it's a plain block. We place local anesthetic in a place where we expect nerves to be without targeting them directly. It does not cause detectable sensory loss of the skin. There's no cutaneous innervation here. And it shouldn't cause a motor block. By and large, it's relatively free of this, although there are certainly case reports of motor block happening, just as there are case reports of the adductor canal block causing more quadriceps motor block than we would wish, but by and large, it's relatively free of motor block, and therefore it enhances early rehabilitation. This cross-section shows the femur. We're just proximal to the knee here. We don't even see the condyle, so we're a little more proximal than we would typically conduct this block, which should be performed just at the top part of the patella or even lower. It can be performed with the needle through the vastus medialis. It can be performed from laterally where the Needle would go through the vastus lateralis to access this region between the popliteal vessels and the femur. A little bit lower down at the level of the condyles, the popliteal vessels pass between those two round condyles, and if a patient's prone, it's relatively easy to see both condyles and access that region with a needle either from medially or laterally. But in all of these cases, it's relatively far away, or should be, from the sciatic nerve and its branches, so should be motor sparing. This ultrasound image shows the femur. This is with the transducer, which is obviously curvilinear here, placed on the vastus medialis muscle, and the needle would be brought through the muscle, skirting along the femoral, the femoral cortex, and come to lie between the femoral cortex, the back of the femur in this instance, because this is an anterolateral position, anteromedial position, between the femoral cortex and the popliteal artery. So the local anesthetic would be deposited in this region. Frequently, you'll see the popliteal artery moving away from the femur, and that's a good sign. Of course, we have to be very careful and identify where the vessels are. Small vessels can be difficult to see here, so it's very important to inject in small gradations and to aspirate frequently. So a couple words about the workshop itself. There will be 4 stations. We'll have 1 rotation during the 90-minute period to a new station. So in other words, participants will not go to all 4 stations. They'll only go to 2, but each of the blocks will be taught at all 4 stations so that everybody gets a chance to do all 4 of these blocks and to do some hands-on scanning, or do hands-on scanning. We won't be able to actually do the block. But at any rate, I hope that you enjoy this. I hope you have fun, and I hope that we are able to teach you some useful techniques. Thank you very much for your attendance, and we appreciate it.